Hey, it's Lindsay. This is my presentation on balance, gait, and reflexes normal, as well as a Parkinson's abnormal. For our neurological exam of our subjective data, we're going to look at their history of present illness. Do they have tremors? Are they unilateral or are they bilateral? Are they experiencing any weakness, decrease in their function, any headaches, hearing or vision changes, gait changes, confusion or disorientation, any decrease in muscle tone, any decrease in being able to do any of their ADLs. For past medical history, we want to know if they have a history of headaches or migraines, any infections that may have crossed into the neurological system, any past trauma such as TBI, strokes, or concussions. For past surgical history, we really want to just know if they've had any past spinal or brain surgeries, and if they have had any other surgeries, if they have any deficits such as some nerve trauma or nerve damage from past surgeries. For family medical history, we're really looking at cancers, dementia, and Alzheimer's, any autoimmune disease, Parkinson's disease, or history of strokes in families. Obviously, with anything abnormal, we're going to follow old carts and get additional information regarding those. When looking at balance, gait, and reflexes for normals, for balance, they should not be swaying. Their trunk should be stable and not needing support. There is some swaying, obviously, with anyone that does any kind of balance, anything. We just sway as natural humans. First thing that we're going to do with them is we're going to do a Romberg test. There should be no loss of balance. They're going to stand with their feet slightly apart, and we're going to push their shoulders. Then we're going to have them close their eyes and have them stand on one foot and repeat, and then have them hop on one foot. And we're going to have them do that repeat on both sides. For the timed up and go, also known as the tug, this screen tool can also check for balance and strength and cerebral function. That just kind of sees how fast they can get up and go from a chair. When we're looking at gait, we're wanting to observe the patient walking without shoes on around hallways or exam rooms. Their gait should be smooth, regular rhythm, symmetrical stride lengths. Arms should be swaying appropriately and at sides. One tool that we're going to be using to see how their gait is, heel-toe walking, also known as a tandem gait. Patient will touch toe with one foot to the heel of the other, walking forward, and then we're going to have it walking a straight line. And then we're also going to have them repeat that same process walking backwards. When looking at reflexes, they should be a 2+, which means they're active and present in response to the exam. Deep tendon reflexes are, we're going to really look at our plantar, biceps, the brachioradialis, and triceps. As well as the patellar and Achilles. Again, we're also going to look at superficial, and that will be the plantar. Another good assessment tool just to have in our minds is the functional assessment, or also known as the Tinity Balance and Gait tool. This is really helpful with our older populations because it helps us assess how they are doing and if they're at any risk for falls, or if they have any troubles doing activities of daily living or any mobility issues. This is helpful in monitoring gait and balance over time with our older population, and it also can be helpful with those with multiple sclerosis or Parkinson's disease. Okay, hi, my name is Lindsay. I'm going to be assessing you today. We're going to start with the Romberg test. I'm going to have you stand straight with your arms at your side. Like that. Okay, perfect. Next, I'm going to stand a little bit with the feet apart. Okay, and then we'll push you just see if you lose balance. No, okay. Again, now I'm going to have you stand on one foot. Your eyes shut. A little bit of swaying is normal. Next foot. Next, I'm going to have you open your eyes and hop on one foot. Yep. Okay, the next side. Okay, good. Now I'm going to have you turn around and walk towards the TV, and I'm going to have you do heel to toe. Okay, looks good. Now I'm going to have you do the same thing, but backwards. Heel to toe. Okay.
So next we're going to check your plantar reflex. I'm just going to have you lift up your foot, kind of putting on my leg here. And okay, and your next one. Okay, next we're going to check your Achilles tendon. advance here a little bit. This one. And next we're going to check his tongue. Just making sure they're equal on both sides. Next we're going to check the brachial radialis. You just want to have your arms out, resting in. The next one. Next we're going to check the bicep. And your next one. So I have your hold your arm and then and okay.
When looking at Parkinson's disease, some findings we're going to find, they're going to have a tremor. Usually that tremor is unilateral. However, it can be bilateral. It is the most common symptom and occurs in 70% of patients. But it does not need to be present, though, to make a diagnosis of Parkinson's disease. They're going to have some rigidity, some bradykinesia, some dystonia, and Parkinsonian gait. Often with rigidity, they're going to have stiffness in limbs, and they're going to have a cogwheel rigidity, which is when we do range of motion in the wrist. It's kind of have that stiffness to it. With bradykinesia, they're going to have slow movement, some lack of dexterity, and they're going to also have some issues potentially depending on where they're at with their upper extremities that can affect handwriting, holding utensils, or other dexterous activities. When looking at dystonia, they're going to, this is more common in younger individuals who are diagnosed with Parkinson's disease, usually with an onset before 40. They're going to have an inversion of their foot on plantar flexing, and they're going to have, potentially they could have their arm or their elbow could now rest on the front of the patient. We're looking at treatment. The gold standard for treatment is obviously Sinemet, which is the carbidopa-levodopa, which is usually taken 2 to 3 times a day, usually starting at a low dose of potentially 50 milligrams, and can increase to 100, and also long-term can increase up to 800 milligrams 2 to 3 times a day, depending on how the patient is doing on the medication and their symptoms. Another thing that's non-pharmacological we can look at is a PT-OT consult to help with that kind of movement with them. Expectation of Parkinson's disease, or kind of how it goes along with them. Mortality rate is about 60% and has been rising in the past decades. Older the age at diagnosis, obviously have that more higher risk of mortality. Male patients are more significantly affected with Parkinson's disease and have higher mortality rates than females. Dementia often goes hand in hand. It can decrease responsiveness to the dopaminic therapies. So some people just don't respond very well to Sinemet over time. Some differential diagnoses that could be also looked kind of at the same as Parkinson's, is Alzheimer's disease and essential tremor, Lewy body dementia, drug-induced Parkinsonian, and muscle atrophy, such as multiple sclerosis. And here are my references. Thanks for watching.